Hello, and thank you for joining us for another episode of Matters of the Heart, a program brought to you by Pentucket Medical Cardiology and Haverhill Community Television. My name is Dr. Sunny Srivastava, and I'm joined by one of my colleagues, Dr. Seth Bilazarian, also from Pentucket Medical here in Haverhill. And we're here today to talk about something that's fairly new and exciting. I know that we're very excited about, and it's specifically talking about a new treatment that's available for many of our patients who have atrial fibrillation. So with that, I'll hand it over to Dr. Bilazarian and let him take it away.
Great. Well, thank you very much for the introduction. And I thought what would be interesting is something we haven't done for our program before is to talk about a brand new therapy. It's only been out for about a month, available on the market. But I also want to sort of have as an undercurrent of our conversation today how physicians, you and I, think about bringing a new drug into our practice and what's involved in that. So what I'm talking about today is a drug that's called Pradaxa. That's its branded name. Its generic name is called dabigatran. And what this drug has been tested has been shown to have very favorable results, which we'll talk about in greater detail, compared to an older medicine, which everyone's heard of, called warfarin or Coumadin. So a trial was done. It was published. We're going to talk a little bit about that. Using this drug, comparing it to warfarin or Coumadin in the problem called atrial fibrillation. So we'll talk about this.
Let's talk about atrial fibrillation a little bit, just to maybe spend 2 minutes just reviewing for the. I know we've done previous episodes on atrial fibrillation, but maybe you can just quickly describe what it is. So, I can do that as well. So atrial fibrillation, it's a very common condition, as you know, and I know it affects anywhere between 6 and 7 million Americans, and it's an irregular heartbeat that, without getting too deeply into it, can render one at higher risk for stroke. And so we have, for as long as I've been practicing, certainly have only had one drug to prevent, one very good drug for preventing stroke in that setting. That's Coumadin, which is a blood thinner. Coumadin is wrought with a lot of problems, requires frequent blood tests for monitoring, which also is a high cost and nuisance factor to it. And as such, there's been a lot of effort put forth to looking at alternative agents. So maybe you can tell us a little bit about this trial and what got us here.
Sure. So I wanted to just talk about what's involved also, just as the undercurrent part of this, is what's involved in bringing this to market. So a large study has to be conducted. Our practice is a little bit ahead in this regard in many areas, but certainly in this area, in that we've actually participated in the study looking at comparing Coumadin to warfarin. This is a large multi-center study around the world, international study of over 18,000 patients. We participated with some of our patients who voluntarily decided to participate. And our patients, including the others around the world, had atrial fibrillation, and they had risk factors for having a stroke. You mentioned that atrial fibrillation increases the risk for stroke. We have a very sort of simple score, which we've talked about previously, called the CHADS score, CHADS. And the CHADS score, C is for congestive heart failure, H is for hypertension, A is for age over 75, D is for diabetes, and S is for a prior stroke. And all of those are 1 point except for the stroke, which is 2 points. And it said that if you have at least 2 points on that score of those 5 letters, you should really be on a blood thinner like Coumadin. That's the current recommendation. So this trial looked at patients who had a score of 2 or more and tried to decide whether it was sensible to use this new medicine or whether Coumadin was something that couldn't be supplanted as an option. So I'll skip to the end and tell you briefly, it looks like this drug has very favorable favorable benefits, both benefits in terms of how good it is at protecting stroke, but also has very favorable risk factors in terms of the risk of bleeding. Of course, we use a blood thinner. We want to prevent clots, but the downside of that is a risk of bleeding issues. So the study was done. It's called the RELY study. And what physicians get, you and I get, are several pieces of information when a new drug is about to be launched. One is the main trial. The trial that we participated in was actually published. So we get a 20-page paper called the RELY study. It was in the New England Journal. We have an editorial, which a leading physician was chosen by the journal, the New England Journal, to actually write about his opinion regarding it. And then subsequent information comes out from other writers comparing this drug to other new options. As you mentioned very well, this is the first drug to replace or even be an option to replace Coumadin in about 50 years. And we have several other drugs that are on the verge of coming subsequently. What we're excited about with this drug, just to walk through this with you, is I thought that you and I could walk through the paper together and talk about the RELY study. So as I mentioned, there were 18,000 patients in this trial, and they were followed for about 2 years, a little bit more than 2 years. And what they found was that, in fact, they compared 2 different doses. I'm only going to talk about 1 dose because the FDA, the Food and Drug Administration, has subsequently only approved 1 dose, the higher dose. They did not approve the lower dose. So they compared Coumadin to 2 different doses of this drug. So we have now only results, we're going to really talk about the practical implications of using this higher dose. So what they found was they compared and contrasted these patients, and what they found, they presented original data in the trial, but we subsequently have new data that was updated, a final sort of update that was subsequently presented in the New England Journal. And I'll just sort of cut to the chase and tell briefly our audience what was found. When they compared these patients who were at risk for a stroke from Coumadin, the risk of having a stroke if you were on warfarin was 1.7% per year. Now, I want to be clear that this is for the study population. These patients had a CHAD score, that score on the 5-point scale, of only about 2. So if you have higher risk, of course, there might have been a higher rate of a stroke. But in this trial, warfarin patients had a risk of a stroke of about 1.7% per year. And if they used a new drug, dabigatran or Pradaxa, it fell to 1.1%. So that's about a 0.6% lowering of the risk of stroke per year. Doctors like us like to use a strategy called the number needed to treat. It's a very practical and easy way to think about how much value this really has. And the number needed to treat, which is really a number that says how many patients do we have to treat with the new drug to prevent the one bad event. And the answer to that on this question is 166 patients. So every 166 patients we treat with the new drug, we'll actually prevent 1 stroke per year. And of course, that number would increase every year. So it would go down. If you said, let's look out at 2 or 3 or 4 years, you would say the number would be much smaller. So it's a very exciting that we have now an option that's not just equally good, that may actually be even better.
How does that number compare, number needed to treat, to other therapies we have out there?
It's drugs? A good question. It's probably a little bit higher than some numbers that we think about, because many of the other numbers we used to think were comparing to placebo. So if you compare, say, what's the number needed to treat for a cholesterol medicine to prevent a heart attack or a stroke after a patient's been admitted with that problem, like we have from a trial called the Prove It study using the drug Lipitor, the number needed to treat was in the 50 range, but that was comparing that drug to a placebo, for instance. So that's what I would say. So moving forward on this, I would say that the number needed to treat for that was very positive. It was statistically significant. Doctors, not us, but biostatisticians and clinical design experts who design these trials have to put a rigorous mathematical formula to prove that it was actually not an accident that this happened, but that it happened by good statistical reason. So statistical chance was really ruled out with a high level of confidence, and that this is a real result, that there was a lowering of 0.6% per year using the new drug compared to the old one. So that's the efficacy, the effectiveness of the drug. What about the risk of the drug? And the main risk of the drug, of course, is the risk of bleeding. We worry seriously about bleeding, but of course we also worry very importantly about bleeding in the brain. So-called intracranial hemorrhage is the most worrisome bleeding consequence because it can often be fatal or cause severe disability if you bleed into your brain. The overall risk of major bleeding, which included intracranial hemorrhage, was a little bit lower with the new drug, dabigatran. The rate was 3.3% with major bleeding versus 3.6% with the warfarin or Coumadin. So that was about a 0.25% lowering, a 1/4%. The number needed to treat in that regard would be 400. So every 400 patients we treat with the new drug, we will prevent 1 major bleed. And every 166 patients we treat with the new drug, we'll have 1 less stroke. So on the effectiveness and the safety side, pretty good signals on a very large trial of 18,000 patients in 2 years.
Now, how about another type of bleeding, gastrointestinal bleeding, also a concern for many patients? What was the difference in that regard?
I don't have that at my fingertips, the GI bleeding, but it's hard to interpret the GI bleeding, I think, alone, because we really concern mostly about major GI bleeding rather than just someone who, say, maybe has a little bit of blood on a blood test of the stool or something like that. So what I would like to ask you as a sort of to begin a dialogue with you, you, I know, have exhaustively reviewed this literature and tried to make the best decision for your patients currently. But based on that, help the audience interpret this for how they might think of it for our patients who are either on warfarin or who might need to start warfarin because they have this atrial fibrillation problem with risk factors for stroke.
Yeah, I mean, I think it's I think the one thing to always, well, let me rephrase that. I think it's very exciting, certainly. And I guess your question is more, how do I approach this with patients? I think it provides a new and perhaps better alternative to warfarin. It's, like, as you outlined, it's a more effective, the efficacy is better, and seems to be a safer drug. There's a couple of downsides to it that I don't think you alluded to so much. One is that the medication needs to be taken twice a day. And two, it's a new drug, and so there's a cost factor. And what have you seen for costs out there for this drug?
Well, let's take your points one at a time. So it is true that this new drug, dabigatran or Pradaxa, is a twice-a-day drug. It has to be taken twice a day because it doesn't last long enough. So if patients only take it once a day, there's a concern that they won't be covered. So they end up only being covered for half a day, so they'd be at risk for the other half a day. So that's a really important issue to think about. In terms of just the nuisance of a twice-a-day drug, it's a little less than normal because the warfarin has been traditionally recommended to be taken in the second half of the day. So patients who are taking warfarin in the second half of the day have to take this drug twice a day, and most of our patients are taking some other drug already in the morning. So it is different, but it's a little less. The second question that you've raised is an important one, and we certainly always want to be sensitive about cost. And there's a couple of cost implications here. One is the cost to the patient, which is, of course, very important. And that cost to the patient is a significant one. Warfarin or Coumadin is generically available, so it can be gotten for $10 for 3 months at most of these pharmacies that now offer a inexpensive plan for the older generic type medicines. $10 for 3 months or $5 for a month is generally the cost for warfarin even without insurance. Some insurances even give this drug for free with no cost because it's an older generic. So that's the cost of the older drug. The newer drug, it's hard to interpret. Different pharmacy insurance plans have different levels, but usually a newer drug will have the highest tier of copay. Some of my patients have been told it will cost them $40 or $60 per month, but you told me that a patient recently said it would cost $15 for 3 months. Right. So it's hard to really interpret. So in my approach to this for our patients has been find out how much this drug costs and help me decide whether you're willing to pay that cost. But it's not just that cost, but there are other costs. There are sort of non-monetary costs. There's time costs. Why don't you talk about that?
Yeah, I mean, I think there's an issue of, these patients who take Coumadin need to come in for frequent blood tests. Or if they're ever going to have, let's say they're going to have surgery, for example, then Coumadin has to be held and more frequent blood tests around the time of the surgery and starting out back afterwards. And so I'm curious about how that plays into the insurance company's decision on which drug to favor or to promote or where to price certain drugs. And there's also the convenience factor for patients and lifestyle issues of having to be tied down to coming to the doctor's office frequently for blood work, not being able to sometimes go away certain times when they may want to go away. So those are issues to be considered as well.
Okay, so I think that the net out, we could agree that this drug is clearly more convenient even though it's twice a day versus once a day. You don't have to go to the doctor to get blood checked, lab tests. But we haven't talked about another issue, and that's an issue about interactions. Of all the drugs that we have to deal with, there is no drug that has more problems with interaction with other drugs, food, or even use of alcohol, even a modest amount of alcohol, than the drug Coumadin or warfarin. This new drug doesn't have really any of those issues. There's really only one drug that is commonly used for patients with atrial fibrillation. That's a drug called amiodarone that we have to be cautious with the new drug. There's pretty much no other drug that's commonly used that we have to worry about. There are no dietary issues. I think our Coumadin patients certainly, but others who know them, know that patients are advised to avoid different intake of leafy green vegetables, broccoli, Brussels sprouts, are cautious about alcohol use. We have to be very cautious with our patients on Coumadin and warfarin if they take an antibiotic. If you take an antibiotic, your Coumadin level will get out of whack and require more frequent monitoring. And there are many other drugs that we haven't even mentioned. It's a laundry list. It's dozens and dozens and dozens, maybe as many as 100 drugs that interact with Coumadin. So for a lot of patients, it's not a problem, but for many patients, starting a new drug can be very problematic and require more intense follow-up. What are your thoughts about that?
I agree. Actually, I'm glad you brought that up. I had slipped my mind about the issue with the drug-to-drug interactions and the food interactions, and so it makes this new drug all the more appealing and exciting. And I guess it brings me to a question that I was going to ask, and this was asked to me just before coming over here by a patient, so it's perfect timing. The patient said to me, it's brand new, it just came out a couple months ago, I'm a little nervous. How do you address that? It's too new for me, is what they say.
Well, I think that's a really great point, and I think that's really a wonderful conversation that obviously you have with your patient to have that conversation that I can't know for sure. Right. I can only tell patients that this was not a small study. They didn't look at a dozen patients or 50 or 100. They looked at 18,000 patients. I would also say that this wasn't the only study. This drug has been developed for clots in the legs and for clots in the lungs. So there's been a lot of other thousands and thousands of patients have been tested with this drug. But the duration of the testing has not been that long. Of course, it's a new drug. So if a patient says, I am not inclined to take a new drug, I want to wait several years to have it tested further and be more confident, I would say that that's excellent. But I think that would be on that ledger of what which drug should we choose. That's one of those things that patients have to decide. But I feel very comfortable in that other question that patients ask us, what would you do or what would you do for your family member? I would definitely switch if the financial aspect of it was tolerable. Yeah. So let's summarize briefly some of the basic things that I think we've said so far. For the new drug is convenience, no issues about having to get your blood tested, and very easy on and off have to be started and stopped for surgeries. And a minor inconvenience of having to take it twice a day versus once a day, but I wouldn't even really put that on the list because of the reason I described. The second issue is that it might be a little bit better at doing the job of preventing strokes, and it seems to have a trend towards maybe being a little bit safer, but we can't really claim that because it's too close. But it's at least as safe, and I think it is appropriate to say it is more effective. So we have a drug that's a little bit more effective and equally safe and has less nuisance but costs more. And let's add the last one on that list of things is it's new, so we don't know about the long-term safety. Could there be a problem at 5 years or 7 years or 10 years? Of course it could be, but this drug and this drug class, this drug is called a direct thrombin inhibitor, have been around for a long time. Right. We use a form of it in the cath lab every day for patients having angioplasties. So it's not like a brand new class of medicines. We have pretty good experience in that regard. So I think net out, most of our patients, in my experience, that I've been using this drug now for a couple of months, have been telling me, yes, it sounds great. Let me find out about the cost. And if the cost is acceptable, I'll go ahead and use it.
Yeah, I'd say in my experience, by and large, most people are very excited about it. There's a few, though, the cost just becomes too prohibitive for them. And that's the only factor for them, really. There's one patient I alluded to earlier today who was questioning the newness of it. That was a separate issue, but for the most part, most people are pretty excited about it, as are we, especially since we took part, as you mentioned, in the actual trial itself. It's been pretty neat to see it come to fruition.
So there are a couple of others that are on the horizon that we haven't talked about today, and we will probably talk about in the future when they come to the market. But for right now, I just want to emphasize what I think that you said very well. For our patients who have this problem called atrial fibrillation, the only current therapy before this drug came to market was warfarin. Aspirin is of no value, and Plavix, which we actually did the study of as well, comparing Plavix to Coumadin, failed. So Plavix, which is a very good drug, and we don't want to say that it's not a good drug for certain problems, like using after a stent or a heart attack, does not do any good in preventing strokes for these patients who have atrial fibrillation. So we're left with only Coumadin before this drug. Now we have an alternative for patients. Many of our patients have a very negative view of Coumadin. They hear about the nuisance factors, bleeding issues, and when patients' Coumadin levels go very high, they can bleed. If it goes low, they're not protected. This new drug gives a very steady level of blood thinning and does not have to be checked. These newer drugs are on the horizon, and we're going to have many more options. And hopefully with that, with competition in the marketplace, we'll see some better cost issues. So I think the horizon is really looking up for patients with this problem.
And what are some of the other ones that are coming out?
Well, the generic names I know, but I don't know the branded names that they're going to be assigned. But one of them is called Rivaroxaban. We were not involved in that one at all, but that will probably be the next one to the market. We've already seen that data at the last heart meeting. So we're expecting that sometime either at the end of 2011 or 2012.
Is there any twist to that one that's different from dabigatran? Or
Well, it's in a different class of medicines, right. but it's still a blood thinner.
Same story, though, as far as it's slightly more effective at preventing stroke and looks to be just as safe, but there's no other twist to it.
I think that there's no twist, but I would say that we can talk about this as a little nuance, is that they tested patients that were probably at higher risk. Using that CHAD score, patients had a higher score. I believe the score was around 3 versus a score of 2. So they had a higher risk of problems, and it showed that it was still better than the warfarin. So that was exciting to see that even patients who were at higher risk were benefited with the newer therapy. And the last one that I'll talk about now, because was one more further out, but the one that's probably, again, another year beyond this one, is a drug called apixaban, which we're participating in that study. And that's already been shown to be superior to aspirin in patients who couldn't tolerate Coumadin. So we're excited about that as well.
Going back to this rely on dabigatran and Pradaxa, there's been a lot of studies coming out looking at other uses for the medication, such as preventing or treating DVTs and things like that. And is that a use that's taking off now as well?
It's not an area that the FDA has yet approved for us, so we have not yet begun that strategy. So I think that that is an exciting alternative for either the prevention of DVTs after an orthopedic type surgery or for problems with the treatment of them. So we don't have that data, but you raise a very good point. I would say that just to emphasize that this has now, in our cardiology space, has been approved as a new option for blood thinning. The title of our program is New Options for Blood Thinning, but it has not been proven for other uses. So for patients who have heart valves, we don't know. It's not safe. It's not safe yet. We haven't proven it. We don't know about it in some other areas that we might want to use blood thinners as of yet. One thing I didn't mention, and I want to be clear, that the one patient population that this drug can't be used at currently for atrial fibrillation is patients who have severe kidney dysfunction. Because this drug is gotten rid of through our kidneys, we need to have decent kidney function. So if a patient has severe kidney dysfunction or is on dialysis, there's currently no recommendation for using this drug at all.
In the few minutes we have remaining, I wonder what direction we should go here. Now the drug's in the market. How, in general, not just with this drug, but in any new drug, how are adverse effects tracked and reported upon, and how is the public kept safe from that regard going forward?
Well, it's an area that I think the FDA has been criticized for, is that there's not really good reporting mechanisms for it. This trial, actually, I think, to complement to its manufacturer, ran a continuation trial. So all the patients who were in the trial got free drug to continue. So we do have a longer duration now that our patients are being followed now for more than a year on the drug. So we're going to be able to accumulate more data in that regard. So longer-term benefits like your patient's concern, I think will be answered in part when this data comes out further.
Gotcha.
In terms of your question about how it happens, the current policy for reporting adverse events, if you and I see a patient and we see some kind of an adverse effect, it's considered a voluntary reporting system. We're supposed to do it, but the method for reporting is somewhat cumbersome, and it's not something that all physicians do. So it is a concern that all of this data might take time to actually get to the FDA, to be able to be analyzing and to report back to the community at large that there might be a new problem or there might not be. My feeling generally is that these large clinical trials, when done by an ethical academic research center, this center was a renowned academic research center that has done most of the atrial fibrillation trials. When it's done with 18,000 patients, it's be surprising not to see some kind of a signal that then could be followed up after the drug is released. I'm not confident that there's going to be no chance that something might be identified down the road. But I think that this drug looks like it has a very good track record. And I think that when new drugs come out to market, I think a vigilance by both the FDA and the manufacturer are really required to bring it to fore so that we know what's going on.
Great. We are starting to run out of time a little bit. I just wanted to round back and ask a few other quick questions about dabigatran specifically, because I know some patients have asked these questions recently. And one being, when someone takes Coumadin and takes maybe too much and their blood's quote unquote too thin, there are medicines that can be given to reverse it, like an antidote, if you will. Well, how about with this drug? Is there anything out there?
Would not be there's not currently an antidote available for this drug.
And is that because the drug is so short acting that it's not an issue, or?
I mean, I would think that people would want to have an antidote. It just has not yet been developed. But the short-acting aspect of it is clearly a preferred approach. With warfarin, as you said, it takes several days for your body to get it out of the system unless someone gives a blood product to reverse it. So that's the antidote that we really have for the warfarin.
And maybe a few quick practical things that, as we're wrapping up here, patients who are going for surgery, for example, or tooth pulling, for example, or deep root work, gum work, how long do patients have to hold the medication beforehand, as opposed to what they used to do with Coumadin?
Yeah, it's generally thought that 72 hours would be more than adequate on this drug to be able to be safely, fully off of the anticoagulant, and then resumption right afterwards.
Great. All right. Well, I think that was an excellent review. We are starting to run short on time. We talked today about a new and exciting, I think revolutionary, if you will, treatment for atrial fibrillation and stroke prevention, and it's called dabigatran. The brand name is Pradaxa, and it hopefully can do a good job of not entirely replacing, but becoming a new option for a lot of patients who suffer from atrial fibrillation. So with that, I'll conclude here. My name is Dr. Sunny Srivastava, and I was joined today by Dr. Seth Bilazarian. Thank you very much.